Thank you very much. Thank you to the organizers for having me. So I'm going to talk about intravascular ultrasound, making it a class 1 indication, not just what the guidelines say now for the high-risk cases, but for all cases. I have no disclosures. As we know from just this conference alone, the evolving role of imaging in PCI, as you see, the PCI complexity has certainly increased with certainly more challenging anatomies, indications in high-risk patients. And we have certainly made advancements in physiology and imaging that now span the pre, peri, and post-PCI phases, right? And we know societal guidelines have increasingly endorsed physiology-based as well as imaging-based lesion assessments. So we know that angiography alone has limitations in terms of lesion and stent assessment, and intravascular imaging, including IVUS, OCT, has demonstrated multiple benefits in multiple studies. And during this talk, I'm going to talk about some of those. And this is widely now being used not only to assess vessel size, but plaque morphology, lesion severity, guide us with stent placement, as well as optimize procedural outcomes. So, and we know that despite all of the technological advances we've had in PCI, guess what? Peri-procedural complications still occur and late adverse events remain non-negligible. And for these reasons, I'm making the case that intravascular imaging should be considered class 1 indication in all coronary interventions because of improved safety, enhanced efficacy, and long-term outcomes. So we already saw this earlier today, both the European guidelines in 2024 and earlier this year for ACC guidelines. Now intracoronary imaging is now considered class 1 recommendation, up from the class 2A that it was in the past. But for both the European and American guidelines, it's mostly for complex lesions. But we know from this paper that was published in JACC last year, 2023, or 2 years ago, intravascular imaging provides information that improve procedural and clinical outcomes. So if you look at the pre-intervention assessment, we can assess the plaque characterization. We did that today, looking at the cases. Do we have 180 degrees worth of calcium? What are the things that may have, what are some of the reasons that we may have failure in terms of the intervention? What is the reference zone, and what is the right size stent that we can utilize? And then during the procedure for lesion preparation and stent deployment, we want to know what that landing zone is. We want to prepare the lesion, determine with the preparation strategy, and really make sure that we are going to optimize the vessel for optimal stent expansion. And then post-procedure, determine if the stent is under-expanded, deformed, or maladapose. We want to make sure there's no edge dissection, hematoma, or tissue protrusion, and also make sure that we did not have any geographic mix. So you can see how it is utilized throughout the whole process, pre, during, and after in terms of imaging. Well, in terms of intravascular imaging, there has been an accumulation of supporting evidence spanning from 2011 to now. Various studies that are listed, large randomized trials that have shown IVUS guidance significantly reduces major adverse cardiac events, MACE, down from 5.8 to 2.9. These are some of the studies. I like to look at it visually. And one of the things you'll see is that when you look at the target vessel failure cumulative incidence, you see these studies have shown an improvement by utilizing intravascular imaging, and not just in any lesions, but in long lesions in all comers in the ultimate trial, and in the renovate and complex lesions. So the intravascular imaging data helps us with helped with consistent and meaningful reductions in terms of target vessel failure. This was a study that Greg Stone put out in Lancet last year. This was the network meta-analysis of 19 trials, 13,000 patients, 1,021 events. And what they did was they looked at the target lesion failure. This was angiography compared to intravascular imaging, PCI, and what you saw in the primary endpoint was a 31% reduction in the target lesion failure driven by 46% decrease in cardiac death, 20% decreased target vessel myocardial infarction, and 29% target lesion revascularization. So really good heart endpoints. The secondary endpoint, interestingly, 52% decrease in the stent thrombosis, and then a 25% decrease in all-cause death and 18% all-cause myocardial infarction. So these are all the reasons to do intravascular imaging in all patients. We've just shown data for improved outcomes, decreasing that major adverse cardiovascular event. Enhanced precision. These studies have shown that we do better stent sizing, apposition, and we know that IVUS leads to further optimization of the stent lesion in up to 30.2% of the lesions. And also in terms of making sure that there's no complications such as dissection or malapposition. We know there's a safety advantage because underpinning the safety advantage of intravascular imaging guidance is this 50% decline in the risk of definite or probable stent thrombosis. And then low risk. Complication rates for intravascular imaging are less than 1%, shown in the PROSPECT trial. And we know in general that intravascular imaging complications are uncommon, but certainly can have vasospasm, dissection, perforation, arrhythmia, or thrombosis. Just like any time that you instrument a coronary vessel, these are possibilities. And certainly we have to be careful if it's a highly tortuous vessels, as we saw today in some of the cases that we looked at. So I know what Dr. Baber is going to say. There are going to be skeptics out there that says, no, you cannot do imaging, and everybody, imaging is unnecessary in simple cases. Well, I'll tell you, even simple lesions benefit from imaging to optimize stent placement and reduce the complications. The central illustration shows you the clinical uses of intravascular imaging. There are many, many reasons to use intravascular imaging for pre-intervention guidance, peri-procedural post-PCI, as I've mentioned to you. So certainly something for us to think about, particularly if we're interested in, as what Marty said this morning, it's all about the patients, and what we want is to reduce complications and do best by our patients. The skeptic is going to say, well, I know, maybe you're right, but it just takes so much time, and it's so costly. I don't really want to. If Sunil Rao was there, he would say, wait, Dipti, what about the cost? Well, we know it's fairly time efficient. You saw today in the cases, it only really adds 5 to 10 minutes to the procedures, so there goes your time issue. What about cost? Well, although I think initial cost and learning curve exist, it really improves long-term outcomes, as I mentioned, decreasing restenosis, decreasing the revascularization rate, and don't forget that 50% decreased stent thrombosis. So ultimately, this decreases the repeat interventions and hospitalizations. And the data does show that it doesn't matter what type of patient, general coronary disease patients, diabetic patient, ACS patients, impaired renal function, there's cost. If you look at the cost incurred to treat patients through the lifetime, they do better with intravascular imaging. What about the last skeptic, which says it's a risky procedure? I mentioned to you earlier, it is a low-risk procedure. The data shows from all of the trials that the complication rates are less than 1%. And then the last, and I know this is the one that probably most people say, well, you can use it, but there are lots of interventionalists out there that don't know how to read these data. What if they make a mistake because they don't know what to do with this data, and they may cause more harm? Well, I will tell you that conferences like this, and certainly ACC, ESC, they all have training modules and things. The training is, there are many, many opportunities to get trained. And then certainly for our fellows, the training has become fairly straightforward. The guidelines support a broader adoption. And the table 3 that's shown over here is programmatic recommendation for the intravascular imaging. This was put out by the Interventional Council for ACC. And this says what operator level education should be, institutional level, and then national level. And the national level, it says training programs should prioritize exposing trainees to an adequate volume of intravascular imaging to achieve competency. And then the last bullet, professional societies should continue to develop and offer lifelong training opportunities and competency tools. And I know ACC does that, even with hands-on experience. So these are things that we can overcome. This is not something that should be a roadblock. So I would say in conclusion, I think this is a call to action. Intravascular imaging improves outcomes. Clearly there's data to support that. It's safe, it's feasible, and it's cost effective. And I think it's essential in every case because better imaging leads to better outcomes and better care. And what did we hear from Marty? It's all about the patient. Thank you very much.